Good evening, everyone, and welcome to the Epilepsy Foundation of New Jersey's webinar, Epilepsy Testing. What is it, why we do it, how to understand what the results mean. The presenter for tonight is Dr. Eric Geller. This is one of a series of webinars that the Epilepsy Foundation has scheduled. So if you'd like more information about upcoming webinars, please visit our website, www.efnj.com, to find out more information. Dr. Eric Geller is a nationally recognized epileptologist and is board certified in neurology and clinical neurophysiology. He joined St. Barnabas in 1998 from the internationally acclaimed Cleveland Clinic Foundation, where he was a member of the Department of Neurology, section of Epilepsy and Sleep Disorders, and head of the Intraoperative Monitoring and Evoked Potentials program. Dr. Geller's major research interest includes epilepsy surgery and diagnostic testing, as well as treatments of epilepsy, including the vagus nerve stimulator, an implantable system designed to prevent or stop certain kinds of seizures. He is principal investigator for the NeuroPace Responsive Neurostimulator System trial at St. Barnabas and co-investigator on the Epilepsy Phenome Genome Project. Dr. Geller received his undergraduate degree from Princeton University and medical degree from Brown University. He did his neurology residency at Harvard Medical School and his epilepsy fellowship at the Cleveland Clinic. He has been named as a top doctor in the New York metro area in the Castle Connolly survey since 2004 and by New York Magazine. Dr. Geller is also the chairman of the Epilepsy Foundation of New Jersey Professional Advisory Board and a member of the St. Barnabas Medical Center Bioethics Committee. This past year, Dr. Geller also served on the Epilepsy Task Force that did wonderful work, which some of you might have read about in our Epilepsy Easy magazine. Questions will be taken by typing in the question into the question section of your toolbar. Dr. Geller will take those questions at the end of the presentation. All attendees will be on mute, so if you have a question, you can type it in, and Dr. Geller will answer that at the end of the session. Okay, I'm going to turn the control over to Dr. Geller.
Okay, can you see me there?
Yes, we can see you.
You're all set. Great. Okay. Well, thank you for all attending and spending your evening with me for an hour here. What I'm going to be talking about is diagnostic testing for epilepsy, what it is, why we do it, and how you can understand the results. Now, it seems obvious if somebody's having seizures, that's what they have, right? And this is one of my favorite cartoons I stole from the New Yorker magazine. If you remember Aesop's fable with the mouse who pulled the thorn out of the lion's paw, and here we have Dr. Mouse saying to patient lion, "It is thorn-like in appearance, but I need to order a battery of tests." You know, it seems obvious, just take it out, but why do you have to do all these tests? And I think for many people, the experience of having epilepsy sometimes is wrapped up in how much testing they have to go through. It requires time, effort, discomfort, glue in your hair, and as well as a lot of money. So you should understand why we're doing these things. And the results often come out in very complicated language. So just looking at the actual reports yourself may be hard to understand what it means. And so what I'd like to do is try to educate you a bit about what we're doing, why we're doing it, and how it can help you. So the diagnostic goals in epilepsy. The diagnosis is figuring out what's wrong with somebody. And we want to know, first of all, is it epilepsy? Are these seizures, or is it something else? If it is epilepsy, what type of epilepsy? There are two main categories we kind of lump things into, either what's called focal or partial, meaning seizures coming from one part of the brain, or generalized, meaning seizures coming from the whole brain. That's important to make that distinction because the treatments can be somewhat different. In fact, the treatments, some of the treatments for one can make the other worse, and there may be treatments that are available for one that are not available for another. For example, brain surgery for focal epilepsy, which you can't do on generalized epilepsy. What is the cause? Why is this happening? And then what are the best treatments? And what we say in medicine, prognosis. What's going to happen in the future? What can we predict? And there are limits to diagnostic testing. Nothing is perfect. First of all, just the word normal, which a lot of people don't like in many circumstances. But we try to say, you may see a test result as normal or abnormal. What does normal mean? Normal basically means that there's no clear abnormality. It doesn't mean nothing's wrong, but it means we can't pick it up on the test. It means the test looks like somebody's test would look like if they didn't have the condition. And it's important to understand different kinds of tests because different kinds of tests have different abilities to be diagnostic and predictive. Can the test detect abnormalities in the first place? That's what we call in science sensitivity. How sensitive is it? Will it pick it up in 100% of the people who have the condition, or 90%, 80%, 20%? And then if you do see an abnormality, does it mean it's epilepsy and not something else? What we call specificity. Is it specific? Does it mean this is the condition and nothing else might be? And sitting here in the doctor's office, very common examples of cases that we see. For example, an 8-year-old child who is reported by the teacher at school to have episodes of staring. Could they be seizures? Could they be attention deficit? Could they be just a bad teacher boring the kids? And here's another one, a 16-year-old who has the first convulsion or grand mal seizure, big tonic-clonic seizure where they fall down and shake, very dramatic presentation. So the most important thing, no matter how much technology we have, no matter how many fancy tests we can do, the most important thing is just taking a history, finding out what happened, both from the person who experienced it as well as from witnesses, because the person having a seizure often doesn't know what's happening during the seizure. They can't tell you that. So getting an eyewitness description is helpful. So we'd like to know what happened before the seizure. Was there enough sleep the night before? Any alcohol use? Any new medications? How were you feeling that day? What were you doing when it happened? From witnesses, what did the person do during the seizure? What did the body do? What kind of physical movements were there? Did they respond? And then how was the person after the seizure? Were they right back to normal immediately, or were they confused, sleeping, unresponsive? Was there any difficulty moving part of the body afterwards? Did they seem to be paralyzed on one side of the body after a seizure for a few minutes? And then also understanding what we call risk factors for epilepsy. These are things that go on with the brain or in the person that go along with a higher chance of having seizures. And so if somebody has something that sounds like a seizure and they have one of these risk factors, we take it much more seriously. For example, any old type of brain injury, if there was a trauma, like a sports accident, a concussion, head injury in a motor vehicle accident, for example, if there was any kind of infection in the brain, encephalitis or meningitis, if there had been a stroke, that's more common in older people, or a brain tumor, for example. People with developmental disabilities, both children and adults, are at higher risk of having seizures. In someone who's having a seizure now, did they have seizures with fever, what are called febrile seizures, when they were a child? That often goes along with temporal lobe epilepsy later in life. Is there a family history of seizures? Does it run in the family? Do the parents or siblings have it? Are there cousins who have it? That may mean there's some genetic type of epilepsy happening. Are there any mood disorders, depression or anxiety, bipolar disorder, or migraine headaches? These have been shown in recent years to have a high association with seizures. People who have either mood problems, migraines, or seizures are more likely to have one of the other three. The first thing we usually do, particularly in the emergency room, is get some blood tests. And the reason we do this is twofold. One is to understand, is there anything out of whack in the blood chemistry? And I'll go through some of those things in detail in a moment. And we also want to understand if we are going to give any kind of treatment, any medication for seizures, how is the person going to respond to that medication? These medicines usually get out of the body through the liver or the kidneys, so we want to know that those organs are functioning well. We also want to check levels of any drugs the patient may be taking, in case those levels are very high, for example. In selected cases, we do what is called metabolic or genetic testing. There are many, many, many different conditions, all of which are rare, that are genetic and inborn and cause a problem either with how the body breaks down food substances, fats, sugars, proteins, that cause a buildup of an abnormal substance in the brain that can then trigger seizures. Or there have been some rare but definite genetic abnormalities identified that can tell us, yes, the person has this kind of epilepsy, and prove that and understand why they have it. The most common blood tests we do are what are called electrolytes. This includes sodium or salt, potassium, calcium, and magnesium. Sodium is very important for nerve and muscle function, and several drugs can lower the sodium level in the body. So for example, if you're taking one of those medications and you have a seizure and your sodium is very low, it may simply be the low sodium that's causing the seizure. It's not epilepsy. Calcium and magnesium, again, very low levels can cause seizures. We see that sometimes in newborn babies. It can also be seen in people with a lot of vomiting or diarrhea, kidney problems, or people on chemotherapy at times. The kidney function, these are a couple of things you'll see on the blood test results. The first one is BUN, or blood urea nitrogen, and the second is creatinine. The CR is the abbreviation. That's what you see on the blood test forms. And the reason we check for these is because the kidney eliminates some medications from the body, and you may need to adjust the dose of the medication if the kidneys are not working well. So you need to give a lower dose. And so you'll see these on the blood test as well. The blood urea nitrogen, urea is a breakdown product of proteins that accumulates if the kidneys are not working well. Creatinine is a protein that comes from the muscles. Normally there's a small amount of it that leaks out into the blood, and if the kidneys aren't working, the creatinine goes up higher. Next are the liver tests, what are called liver enzymes. And the liver is an organ that you can think of as kind of the garbage disposal for the body. It gets rid of many medications and other toxins and just breakdown products that your body creates as you're digesting food. And the liver enzymes are proteins that do the work. Normally, a small amount of those proteins leak out of the liver into the bloodstream. And if there are high levels of these enzymes in the blood, that can mean that the liver is being damaged. Very slight elevations of these liver tests are very common with certain of the epilepsy drugs. The abbreviation AED there means anti-epileptic drug. You'll see that a few times in my talk here. Very high levels of the liver enzymes can be worrisome and may mean that we need to take the person off of the medication. Many of the anti-epileptic drugs can affect the liver. In particular, the ones we worry about the most are valproate, also known as Depakote is the brand name, felbamate, the brand name is Felbitol, carbamazepine, that's known as Tegretol, Tegretol XR, or Carbatrol, and phenytoin, also known as Dilantin. Those are the most common that affect the liver. Another common blood test we do are for the blood cells. And there's 3 different kinds of blood cells we care about. The first are the white blood cells. These are the blood cells that fight infection. The next are the red blood cells that carry oxygen. That's what makes our blood red. The blood tests that you would see on the form would be listed as hemoglobin and hematocrit. Those are 2 different ways of measuring the number of red blood cells. And then there are platelets. Platelets are tiny little blood cells that help our blood to clot when we have a cut. And some medications can lower the blood cells, sometimes dangerously so, or prevent the bone marrow from making the blood cells. And that can be a very dangerous situation called aplastic anemia. And the seizure medicines we worry about the most with respect to the blood cells are carbamazepine, which can affect the white blood cells particularly, cause a low level of those. Valproate can affect any of the blood cells, but in particular, it can affect the platelets. It can cause low platelet levels that could cause somebody to have easy bruising or bleeding. It can also act on the platelets like aspirin. Aspirin actually blocks the platelets. That's how it thins the blood and prevents strokes and heart attacks. Valproic can act like that. So even if the platelet number is normal, sometimes there can be easy bruising. And then felbamate, which is a drug that's not used very much because of warnings that came out about how it can cause severe damage to the bone marrow or the liver. And so we check the blood cells to make sure the medications are not affecting them. Another very common blood test are the levels of the anti-epileptic drugs. Now, why do we check the levels? Well, first of all, we want to verify the person is actually taking the medication. For example, if somebody is supposed to be taking a medicine and then they have a seizure, unexpectedly, maybe the level dropped for some reason. Either they're not taking it or they're not absorbing it properly. They might have vomited or had diarrhea and can't keep the medication in their system. The Motor Vehicle Commission likes us to check blood levels to show, yes, the person is taking the medication. Checking the drug levels also can help us gauge how the body handles the medication and can help us with adjusting doses. For example, children chew up these medications much faster than adults, so they may need higher doses per pound of body weight in order to maintain a good blood level. And then, as I said, if somebody has a seizure, did it happen because the level was low? Or if somebody is complaining of side effects like drowsiness or dizziness or tremors, is it because the levels have gotten very high? It's very important to check if the dose has been changed or if other medications have been added that might interact or affect the seizure medications, or if there are any unwanted symptoms, to see if the high level or low level are causing the problems. And now what the blood test forms will show is there's a so-called normal range. And what that means is that most people taking this medicine would do well with seizure control and no side effects. It's somewhere in that range. Now that doesn't mean that being in that range is going to stop seizures. And it doesn't mean that being outside that range is bad. We're treating a person, not a number. If you're doing very well, the dose should not be changed just to get somebody into the range. We just need to find out what the level is that works for you, not what works for most people. Really, the most critical test in dealing with epilepsy and seizures is the EEG, or electroencephalography. This is the brainwave test, and it was discovered a long time ago, 1929, by Hans Berger, who is a scientist in Germany. And the way we do the test is we glue some wires that we call electrodes, little metal discs, onto the scalp. And what this does is it picks up the electrical fields of the brain that are generated by brain activity. And the brain actually works electrically. It's an electrical organ. And so we can see certain kinds of normal and abnormal features on the brainwave test, on the EEG. And it's really the test that allows us to diagnose epilepsy. No other test can prove somebody has epilepsy or not. And the terms that we use on the EEG that you'll see if you look at an EEG test, the first are called spikes, or also known as sharp waves. I'll show you some examples of these. These are very rapid, pointy brain waves. They last a very short period of time, and they go up and down so quickly it makes a wave that looks like something very sharp. One of my teachers said, it's a sharp wave. If you sat on it, you'd go, ouch. You can also see seizures happening on an EEG. And the EEG can help us tell, is the seizure coming from one part of the brain, the focal seizure, or is it from the whole brain or generalized? And I'll show a few examples here. This is a page of an EEG from somebody who's 43, a woman, with a condition called juvenile myoclonic epilepsy, or JME. That's one of the generalized epilepsies. And let's see, I have my mouse here. And so what I'll show you is going from left to right across the page here. We start from the left and go to the right, just like we're reading a book. And each one of these squiggly lines here is coming from a different wire on the head. And each of these very light vertical lines, you can see, represents 1 second in time. So we have about 10 seconds going from left to right here. And what you see is here are normal brain waves coming through this first second, and then here's a very dramatic change. And what we see is this very pointy brain wave here followed by a bump. This is called the spike and wave. And it's happening about about 3 times per second. And then it's lasting 1, 2, 3, 4, 5, about 6, 7 seconds here. And so this is a generalized burst, and this could actually be a little seizure, what's called an absent seizure, where somebody isn't responding normally. They may blink or stare or just not respond very quickly during that time, and then they should be fine right away, and the brainwaves go right back to normal immediately. So they should be fine. So this could tell us that this is in fact a generalized epilepsy, because you see it really all over. Every single one of these wires has that spike and wave. Here's an example of an 8-year-old child with a history of staring spells that has a focal epilepsy. And what you can see is very different than the previous page. Now we're looking at here normal brain waves here, and the top 4 lines across here are coming from the left side of the head over around on top of the ear. The next 4 lines here are coming from the right side of the head, also on top of the ear. And what you see here are these very pointy brain waves here, and they're not happening every single second. They're happening pretty frequently. This child is asleep, actually. And these are just happening in these channels. And down here, this is the right side of the head again, over towards the top of the head. And here's the left side. So we see that it's really just on one side of the head in one area. And so that tells us this child has a focal epilepsy. Now here's an actual seizure, and you can see how dramatically things change here. This is from a 3-month-old who has a condition called neurofibromatosis, and the seizures involve the eyes just turning to one side repetitively. And the vertical lines, again, these vertical lines represent 1 second, so we actually have more like 20 seconds on the page here. And you see something is happening all over here. Here are these squiggly lines. These are normal brain waves here. And then right here, there's a big disturbance all over. And then things kind of flatten out in this region here, but then we get this very repetitive, very big wave happening once or twice a second, and we start seeing some of those spikes, those pointy brain waves coming in there. So this is really changing, or what we call evolving. It starts out with one depiction, and then it changes over time. The waves get faster. They take up a different part of the brain. The rhythm changes, and so that's how we define a seizure on the EEG. There are many, many different types of seizures. This is just one example to show you of how dramatic that can be. Now, the so-called routine EEG we do in the office for 20 minutes, half an hour, sometimes more than an hour. But generally, you're awake or maybe drowsy. Sometimes if you're up late last night, you'll sleep during the test. But it's a very short period of time. And those abnormalities I was showing you before, those little sparks, don't always show up on the short test. Sometimes, like in the 8-year-old child I showed you, they only show up during sleep. So you really have to catch a good night's sleep on the test. The other thing is that it's very rare for somebody to have a seizure in the doctor's office. It does happen, but very, very uncommon. Maybe a few times a year I'll see somebody have a seizure here in the office. So the doctor usually never gets to see the seizure. So we have a technology called video EEG, which was developed actually originally in the 1960s using technology that NASA was using to monitor the astronauts that they were going to send to the moon. And with this testing, it really led us to our current much better understanding of different types of seizures and different types of epilepsy. And I always explain it to my patients that this is kind of a brain stress test. What we want to do is bring you in the hospital for several days, record the EEG continuously. At the same time, there's a video camera and a microphone recording pictures and sound, because I can't stand there watching you the whole time. And so we'll try to catch some of your seizures there. And this, in adults, this typically takes about 5 to 7 days. And we do things to try to make the seizures happen in that period of time, like withdrawing the medication, lowering the doses, or stopping the medication, doing what's called provocative testing or activation procedures like the strobe lights or hyperventilation, the deep breathing, keeping people up late at night, lack of sleep is a real trigger, sometimes alcohol, sometimes other things. And sometimes we may use special electrodes that cover other parts of the brain that we don't use on the standard testing in the office. And so this is really an excellent test for us to find out what's going on. Now, why do we do video EEG? What are the so-called indications? The word indication means why are you bothering to do this? And for people whose seizures are resistant to medication, it's very important to understand why are the seizures resistant. Is it because they're on the wrong medication? Is it because maybe they have something that isn't epilepsy? Or maybe they have a condition that is very resistant to seizure medicine and they need some other type of treatment. And so we bring people in to see the seizures. It also allows us to make sure the person is not having seizures getting out of control if we have to do a very rapid medication change or if they're very ill, for example, throwing up and can't keep down their medication. And then it also helps us determine what's the next step in treatment. Maybe changing medication, maybe leading somebody towards brain surgery that might get rid of their seizures completely, or what's called VNS, or vagus nerve stimulation. That's another kind of treatment, a pacemaker, that I'm not going to go into in too much detail tonight. And this is, these are some pictures from our video EEG unit on the right. You see me examining one of our patients, and the technologist is gluing the wires to the head, just doing the neurological examination. On the left is my partner, Dr. Rena Goldberg. And you can see the EEG is recorded on computer screens. It's on computers, and we see it on screens, and we have the video where we can see people and see what's going on. Another kind of EEG testing we can do, which a lot of people prefer, is what's called ambulatory EEG. Ambulatory means walking around. And so people come to the office, we glue on the wires, and the wires record into a small box, which you can see down here. Here's a child with the head wrapped up with some gauze to keep the wires on. And the box is in a little backpack, or for adults we have a kind of a little pouch. And this is a picture of the technology we use, of the product we use. And there's a little display screen that has the time on it. And here's a button to push, so that if you have a symptom during the recording, you can push this button to put a mark on the recording so the doctor can see what the brainwaves are doing exactly at that time. And also we give you a paper diary to write down what symptoms you had and what time it happened, so we know how to correlate the symptoms with the brainwaves. And you can go home with this. You don't have to stay in the hospital. A lot of people like that a lot. Some people don't like walking around at home or being out with the wires on the head, but it's in some ways much more convenient than coming in the hospital, much less expensive than coming in the hospital. And it asks different questions. For the video EEG in the hospital, we're asking, what's wrong with this person? Let's see the seizures. Let's see what's going on. For the ambulatory EEG, usually what we're not expecting to see a seizure necessarily. What we're looking to do is see, how is the person doing on their medication at home? Are they well controlled enough to drive a car, for example? Or if somebody has only had one or a couple of seizures and can't come in the hospital, then we can send them home with this and look for those little spikes, those sparks that the brain gives off in between seizures, and see if we can pick something up. Sometimes people just don't have seizures in the hospital. For some reason, the hospital is less stressful than being at home is, and they just feel more relaxed and the seizures don't happen. So doing the test at home can sometimes be more likely to pick up an episode. So EEG is extremely useful, and we use it many, many times a day, but it can be misused as well. A normal EEG does not rule out epilepsy, particularly the short routine 20-minute, half-hour tests that I mentioned. I've had people call me up and say, gee, my EEG in the office was normal, so I can stop taking my medicine, right? And that's not true. That's not true. Somebody with very bad seizures very frequently can have 20 minutes of normal brainwaves at a time, and the normal test is just unhelpful. Now, an abnormal EEG may not confirm epilepsy necessarily. So you have to correlate it with the symptoms that the person has. For example, typically one side of the brain controls the opposite side of the body. So the left side of the brain would control the right side of the body. So if somebody comes in and says they were having seizures involving the right side of the body, and I do an EEG and it shows something on the right side of the brain, it may be abnormal, but it doesn't necessarily explain what's going on with them. Also, expert reading is really important. EEGs are often misread. It's a very complicated test to learn to read. People who are board certified in it have at least 1 to 2 years of fellowship training after their training as a neurologist. During regular neurology training, you may have 1 or 2 or 3 months of learning how to read an EEG. So there are often mistakes with EEG, and it's worth getting a second opinion. Many times when people come to me for another opinion, I'll ask just to look at what the actual test that was done before rather than repeat the test, just so if I can see if I have the same opinion about it or not. Sometimes repeat EEGs may be necessary. The first test may not pick something up, and if you repeat it several times, you may find something finally. And then if the outpatient EEG, the one done in the office, is normal, then doing a more prolonged EEG may be necessary, like the ambulatory or the video EEG in the hospital. All right, so we've talked about brain function with the EEG. Now I want to talk a little bit about the brain structure, how the brain is built, taking pictures of the brain. And there are several different ways we can do that. And one very common way that's been around since the 1970s is what's called the CT scan or the CAT scan. And this is an X-ray test, but instead of taking just a single frame the way, for example, a chest X-ray would, this allows you to take multiple X-rays and make kind of like slicing a loaf of bread to see the inside. Now, unfortunately, the CAT scan is not very useful for people with epilepsy. It's useful to see if there's a skull fracture because bone, the bone of the skull, is seen very well on an X-ray test. It can also tell if there's been bleeding in the brain after there's been a head injury. But it's very low sensitivity. It does not pick up the typical causes of focal epilepsy. And this is because it's kind of a fuzzy test. It doesn't pick up much detail in the brain. The brain is surrounded by the hard bone, and the bone blocks the X-ray, so you don't see much of the brain. So I usually avoid the CAT scans. The other thing to worry about, there's increasing evidence that having repeated CAT scans and lots of X-ray tests, the radiation can increase the risk of cancer. And so I don't like doing CAT scans. And I see too many times somebody has a seizure out in public or on the street, they're brought to the emergency room, and the emergency room feels like they have to do a CAT scan every time, even though it's somebody who's known to have epilepsy, is on seizure medicine, has had an MRI scan of the brain before or some other testing, and has a diagnosis. The CT scan is usually not necessary in that case. The test that we really prefer is called the MRI, or the magnetic resonance imaging. And this test does not use X-rays. It's not a radiation test, and it's completely safe. What it does is it puts the person's body in a very, very, very strong magnet, big magnet. You can see down here, here's a little photo I stole off the internet of a person going into this big tube here, and there's a little hole in it. Some people get a little claustrophobic in it because you're surrounded mostly by the machine. And every few minutes there'll be a repetitive loud banging noise, kind of like a hammering noise. Nothing's touching you, it's just the noise of the machine working. And this gives us really beautifully detailed pictures of the inside of the brain because the magnetic fields go through the skull, whereas the X-rays don't. So there's no radiation exposure. It's safe. Sometimes we may need to do a dye injection of what's called contrast, or GAD, or gadolinium is the chemical name of it, and that can help show us if there are brain tumors or inflammation. But the MRI is so good now that we really don't need it to pick up an abnormality. We need the contrast to tell us if there is an abnormality, what might that be. And when MRI came out a long time ago, There was a study looking at a large number, 340 patients with partial epilepsy, and about 92% had some abnormality on the MRI scan, so it can be a very good test for people with partial epilepsy. Again, like EEGs, not all MRI scans are equal, and the MRI scans vary both by the equipment and how they're programmed on the computer. For example, we look for what's called high resolution, which basically means more detail. And the stronger the magnet, the better the MRI scanner. And so, for example, the standard up until a few years ago was what's called 1.5 T. T stands for Tesla, which is the strength of the magnetic field. Now we're up to 3T in standard clinical practice, and in research labs they have up to 7T. And when you're looking at people for causes of epilepsy, in particular we're looking at a part of the brain called the temporal lobe, which is under the temple, you need to do what are called coronal images. These are images taken as if you were looking face on at the person. So that shows the inside of the temporal lobe the best. And you want to do very thin slices. The standard MRI scan makes slices that are about 5 to 7 millimeters thick, so maybe about a third of an inch thick. And the way I describe it to my patients is, imagine you want to count all the raisins in a raisin bread. If you do very thick slices, you might miss a raisin buried in the slice. If you do very thin slices all the way through from one end to the other, you'll see all the raisins. This is the best way to look at a part of the brain called the hippocampus. That's a deep part of the temporal lobe. It's a very small structure, and you need to see it with high detail in order to tell if there's something going on there. It's a very common source for seizures. And MRI scans can pick up abnormalities. Remember, I used the word sensitivity. So if somebody actually has an abnormality, what's the chance it will pick it up? It's somewhere between 76 and 100%, depending on which study you look at. And how specific is it? About 86 to 100%. So very good testing. Now, many people get claustrophobic in the MRI and ask for what's called the open MRI. Basically, that means the MRI scanner is further away from your body. And it's more comfortable, certainly, but because the MRI scanner is further away, the pictures are fuzzier. Imagine taking a photograph close up to somebody versus being very far away. Even with the telephoto lens, it's not going to look quite as good. And then there's a type of MRI scan, what we call sequence, or a way of doing the MRI called FLAIR, F-L-A-I-R, which can show certain kinds of abnormalities much better, especially in the temporal lobe. And I'm going to show you some pictures in a moment, but kinds of things we look for in the MRI are called mesial temporal sclerosis or hippocampal atrophy. That means there's some scar tissue deep in the part of the brain called the temporal lobe. We can see brain tumors, what are called vascular malformations or abnormal collections of blood vessels in the brain. If there's been any old scar tissue from trauma or injury. And then what are called malformations of cortical development. Basically, these are abnormalities in the brain of how the brain was built when the person was a fetus or a young child. And I'll show you some of these examples here. The first example, this is somebody we did surgery on many years ago who's remained seizure-free. These are what are called coronal images. Imagine you're looking face-on at the person. Here's the person's right ear. Their left ear would be over here. This is the top. This is the bottom. They're looking right at us. And this part of the brain here is called the temporal lobe. Here, we're looking, there's one on each side, the left and the right. And you see this sort of oval structure here, kind of gray, and that's called the hippocampus. That's what I was talking about before. And I think it doesn't take a lot to see that on the left side, it's bigger than it is on the right side. The right side is much smaller. There's some scar tissue there. And this was the standard, what's called T2 image, and what that means is areas that have more water show up as white. So here's where the spinal fluid lives. That's very white. And we're trying to look at the hippocampus, but it's right next to that spinal fluid, and the white kind of spills over. And on the FLAIR image gets rid of that white from the water that moves around, but it stays white in areas that have water trapped in the tissue. And you can see this area here is whiter than that area there. And that indicates, again, that there's a scar over here. And so we were able to successfully take out that scar, and the person has not had a seizure in the last 13 or 14 years. Here's somebody where we use a dye injection. And again, we're looking at face-on at them, and here's the temporal lobe a little further in front. And you see this sort of black area here. And it does not really light up with the dye, so it's not a tumor. And here's that same person with the flare image I showed you. See, that shows up very white, so that stands out much more. It tells us, yeah, there's something going on there. And then before we did surgery on this person, we were looking at the MRI scan, and we saw, gee, you know, there's a little white spot there and a little white streak there. What's going on here? And it turned out he had a condition called tuberous sclerosis, which is a genetic condition that causes these benign growths in the brain that can cause seizures. And again, he did very well. His seizures came from this area. We took it out, and the seizure stopped. Here's somebody with an area called what's called dysplasia, or malformation of the brain. This little white streak here, and you see that this little black area indicates there's a little missing brain tissue. There should be brain filling all the way inside the skull, and it's not there. Then here's somebody who sounded like she had temporal lobe epilepsy, just like the first person I showed you. But when we did the MRI, again, this is the person looking towards us, their right ear, their left ear over here, and we're towards the back of the brain. You see this black area here is the spinal fluid area, and see this kind of grayish tissue around here. And that's a whole bunch of brain cells that started out life down here, and normally they should go out to the surface of the brain here, but they didn't. They got stuck here. And that's not something we can operate on. So I'm running a little short on time. I'll start moving along. And then let me talk about some more advanced testing, which are really testing the function of the brain. Not just how the brain is built, but how the brain is working. And there's a whole slew of tests here that I'm going to mention, and these are used primarily for people who were thinking about doing brain surgery to treat their seizures. The first is what's called neuropsychological testing, and this is the paper and pencil testing, kind of like taking the SAT all over again. Oh, joy. And it assesses what's called cognitive function, your thinking function, memory, language, what are called executive functions, decision-making. And it can be useful for people with epilepsy for many reasons, particularly for children. It can help us set appropriate educational and vocational goals. It's very important for pre-surgical testing because it helps us evaluate both areas of strength and weakness. It's not a test you pass or fail. What we're looking for is, because different parts of the brain do different things, we want to know what are the strengths, what are the areas that are working well, and what are the areas that are not working well. Because often the area causing the seizures is not working well, so it helps us confirm that's the spot. And if that spot is not working well, if we do surgery on it, take it out, you're unlikely to have a new problem. If it's functioning very, very well, then we may not want to do surgery and cause loss of any function. Another type of neuropsychological test we do for surgical patients is what's called the WADA test. Dr. WADA in Japan invented this many, many years ago. The official name is the Intracarotid amobarbital test, and what this does is we have to do an angiogram or stick a thin little tube into an artery in the groin, run it up into the neck, into what's called the carotid artery, which goes to the brain, and inject a short-acting anesthetic called amobarbital to shut down one side of the brain just for a couple of minutes. And that allows us to tell, does the awake side of the brain talk? Can you still talk or not? And if we show you pictures and objects, will you remember them later? How good is the memory on the awake side of the brain? There are what are called nuclear medicine testing, and nuclear medicine is basically an inside-out X-ray. Instead of the X-rays coming from outside you, going through you, and coming out the back onto the film, what we do is we inject some type of radioactive chemical that goes to a target organ, and then the picture is taken. So it gives off the radiation from inside the body, and we can see where that chemical went. In particular, for brain function, we want to look for increased or decreased neuronal or nerve cell activity. And we can also look at different neurotransmitters. These are chemicals that allow one brain cell to talk to another. The most useful one is called the PET scan, or PET, positron emission tomography. And we use a chemical called FDG, which is similar to glucose or sugar. However, once it gets inside the brain cells, it can't go anywhere. It doesn't get broken down like sugar into energy. And so it sits there for a little while, and we can take a picture of where it went. And if you see what's called hypometabolism, if you look at your PET scan report, they may say that, hypometabolism. That means decreased uptake of this sugar. And in temporal lobe epilepsy, it can be as high as 90% of people who do well with surgery will turn out to have this hypometabolism. Outside the temporal lobe is called extratemporal lobe epilepsy. It's lower, but still can be very helpful. And this allows us to go right to surgery for people rather than trying to put wires inside somebody's head to figure out where the seizures are coming from. I'm going to skip that slide. In the interest of time, there's what's called the SPECT scan. This looks at blood flow rather than the sugar. And it looks where the blood flow is going over a period of 1 to 2 minutes after the injection. And if you can time it right and do the injection right when somebody's having a seizure, you can see the area the seizure is coming from, possibly. It's a very difficult test logistically. You have to have somebody sitting by the person in the video EEG unit all day, holding this syringe, waiting to give the injection, waiting for seizures. That often doesn't work out. And here's an example. Here we're looking at somebody's brain. This is their right side and their left side of the brain. And you can see here, ictal, what's called during the seizure, you see this red spot here that's lighting up. There's no red spot on the corresponding other side of the brain. And then in between seizures, the two sides of the brain look very similar. So something's lighting up here that isn't different here, and that helps confirm that that's the area for the seizures. I'm going to skip this test because we don't do it very much. Here's a test that's been growing, at least in the press and popularity, called magnetoencephalography, or MEG, or MEG. And it allows the detection of very small magnetic fields from the brain activity. And it sometimes may see things that you can't see on the EEG, because the EEG just looks at the surface of the brain. It doesn't see very deeply in. But these magnetic waves, instead of the electrical waves, the magnetic waves come through the skull much more easily, just like the MRI scan can see the brain much more easily because it's magnetic. However, unlike video EEG or ambulatory EEG, where you can do it for days at a time, this is only about 1 hour, so it's more like a routine EEG. And it allows you to map out these abnormalities on the person's MRI scan and try to see more precisely where things are coming from. Excuse me. There's also something you see in the newspapers called functional MRI, where you look at rapid changes in blood flow during some type of brain function and try to figure out where that's coming from. And it's really a research tool in dealing with epilepsy, but may help us figure out where somebody's movement, sensation, or language areas are prior to doing brain surgery. And here's just a little spinning brain. And you can see these red areas there are areas that are activated with the functional MRI, and the blue areas are areas that are deactivated during some particular task. Another important test, which we do to try to figure out if we can operate on somebody's brain to cure their seizures, is invasive EEG. What that means is we do surgery, or the surgeon does the surgery, I don't do that myself, to put EEG wires inside the head, either inside the brain or on the surface of the brain. It can be up to 128 wires or more. And this helps us figure out what's called the epileptogenic zone. That's the area where the seizures are starting from. It also allows us to map out critical function areas like speech and movement, and figure out where it's safe to operate and where it's not safe to operate. Now, this causes increased risk for the surgery because it's two brain surgeries, one to put them in, one to take them out. Then you're spending about a week in intensive care doing all this brain mapping. But it lowers the risk of any new neurological problems like paralysis or speech loss or memory loss. And here's an example of a patient we operated on many years ago, and just kind of a cartoon that I make. This is what's called a grid. Each circle represents one of the EEG contacts, and there's 8 by 8, so 64 different ones here. And on this side, you can see these little lightning bolts mean that's where the seizure came from. And then over here, we look at the person's function. All the yellow areas are areas where the stimulation caused problems with speech. The red areas are involved in movement, this little tongue here. Kind of stole that from the Rolling Stone logo. That shows movement of the tongue, movement of the hand. These are movements of the face here. And these areas called aura, that's where we reproduce the person's seizure aura. And you can see that there's pretty much a dividing line between where the seizure came from and where all this critical function is, so we're able to operate successfully without causing any new problems for this person. So now, once we've done all these tests, we need to kind of put it together and create an answer for you. So what is the epilepsy diagnosis? We want to understand what kind of seizures there were based on the history, based on the video EEG, for example, called the seizure classification. We want to understand the epilepsy syndrome. Epilepsy syndrome is an epilepsy condition where there are many different features that go together, and I'll show you a few examples of this. We want to understand what we call the etiology. Etiology means the cause, why this is happening. And are there any other associated conditions, such as memory problems, mood disorders, other medical conditions? And here, let me give you a few examples of what epilepsy syndromes look like. Here's a very common one, childhood absence epilepsy. And this starts at about 6 or 7 years of age. Sometimes they may go into GTC, or generalized tonic-clonic seizures, in adolescence. It's a fairly frequent family history of seizures. The child otherwise looks normal neurologically. There's no cerebral palsy or paralysis or developmental delay. And the seizures have a brief arrest of activity. There may be some blinking. No postictal state. That means the person is back to normal right away after the seizure. And they can happen many times a day. When they're not having a seizure, the EEG looks pretty normal. When they are having a seizure, they have what I showed you on that first EEG slide, the 3 per second spike wave complex, SWC. It's what we call idiopathic, meaning really genetic. There's nothing otherwise wrong with the brain. The MRI should be normal. And the prognosis can be pretty good. It's usually controllable with medication and may remit. It may go away over time. This is one of the seizure problems that you can grow out of. Here's another idiopathic generalized epilepsy called juvenile myoclonic epilepsy, or JME. Juvenile means it comes on in the teenage years, between 12 and 18 usually, often unrecognized initially until they have the big seizure. A fairly frequent history of family involvement. Again, neurologically normal, no developmental delay or paralysis or anything like that. And people may get what are called myoclonic jerks. That's one type of seizure. That's why the seizure classification is important, especially in the morning when they wake up. And they may have tonic-clonic seizures. And infrequently they'll have the absence seizures, and they have this generalized spike wave on the EEG 3 to 5 times a second for bursts of several seconds. And this is known to be genetic. There has been at least one gene identified that may go along with this. And an important thing about finding this condition, making this diagnosis, is the prognosis. It doesn't go away. You really generally need lifelong treatment. However, it's usually well controlled with the right medication. And it also allows us to tell people to avoid certain triggers or precipitating factors like lack of sleep, alcohol, and allow people to adjust their lifestyle to try to keep the seizures under better control. Another condition called Lennox-Gastaut syndrome, it's another generalized epilepsy, starts in childhood typically. Sometimes children start out without any problems, but they may have a pre-existing developmental delay, or what's called encephalopathy, or have epilepsy before, and a high percentage have what's called West syndrome, or infantile spasms, and then they grow into the Lennox-Gastaut syndrome. And there are multiple seizure types. This is also known as the mixed seizure disorder. They may have tonic seizures in particular, where the body stiffens and the person falls. Absence seizures frequently have status epilepticus, or continuous seizures. There may be an abnormal background on the EEG with a lot of generalized spike wave. Many different causes for this, and the prognosis can be poor, and seizures can be very hard to control once you identify this condition. And then mesial temporal lobe epilepsy. This is what we do surgery on most commonly. May start out in childhood, but can come on in adult years. Neurological examination is often normal, but memory and language may be impaired. They often have an aura or a warning, such as a funny feeling in the stomach, or a smell, bad taste, or a sense of deja vu, a sense that things happened before even though they know they didn't. And then go into the complex partial seizure, where they stare, don't respond, may have some funny movements with lip smacking or fumbling with the hands, and may be confused afterwards. And you see these spikes in between seizures, interictal, in one or both temporal lobe areas. And the cause can vary. There can be tumors or blood vessel problems, or it can be the MTS, mesial temporal sclerosis, that scar that I showed you on that first MRI scan. And it's important when you recognize this condition early on to know that about 70%, 7 out of 10, are going to be resistant to the medication. And so we may think about doing brain surgery earlier than later to prevent further disability. And so the prognosis or outcome of these different syndromes, the so-called benign ones, the idiopathic ones, people may be neurologically normal and may grow out of it or are usually well controlled. And then what are called symptomatic epilepsies that are harder to control. And the focal symptomatic epilepsies often require surgery. And so where does one do all this kind of testing? Well, there are now a growing number of what are called comprehensive epilepsy centers. And this is where we offer neurologists, or what are known as epileptologists, people who specialize in seizure management, neurophysiologists, meaning people who read the EEGs expertly, neurosurgeons who operate on people, radiologists who are very educated in the causes of seizures and how to recognize them on MRI scans, neuropsychologists who do the testing I described to you, nurses who are specially trained in managing people with seizures. They're not scared of taking care of people with seizures the way many hospital nurses are, and EEG technologists. And we offer all the available technology, the video EEG, MRI, PET scans, epilepsy surgery, vagus nerve stimulation, new medications. Epilepsy centers can be very useful not just for people with hard-to-control seizures, but people where the diagnosis has not been clear, and they need to find out do they actually have epilepsy or not, or are there treatment issues, for example, a woman who's pregnant and has seizures and needs to be on medication, or people with other medical problems like they're on kidney dialysis or have liver failure or have cancer and are on chemotherapy. And the referral to an epilepsy center can be very delayed. The average is over 15 years from the beginning of the seizure to actually getting to a specialty center. So in conclusion, diagnosing epilepsy can be a complicated business. And no matter how fancy our technology gets, nothing is more important than taking a good history, just finding out from the person and their family or eyewitnesses what actually happened. Ideally, we'd like to come to a level of diagnosis where we know the epilepsy syndrome. The so-called old test, EEG, MRI scan, and so forth are adequate for most cases. And these newer tests like PET scan, MEG test, and so forth are very helpful for more difficult diagnoses or surgical cases. And it's always worth reevaluating periodically. So if we haven't found an answer now, maybe things will become easier to figure out in the future, in a month, a year, several years. So it's always worth revisiting after a period of time if things aren't going well. I'm going to end with this picture. The first time I gave a talk like this, I had gotten this slide. I was giving it at the Exceptional Parent Conference down in Florida, and I was getting in and out of Florida just before this hurricane. Just thinking about after Hurricane Sandy here very recently, you know, kind of what we do is kind of like what the weather people are doing. We want to figure out, you know, what's the diagnosis? Is this going to be a bad storm? What's the prognosis? Where is it going to hit? Who has to get out of the way? What's going to happen? What kind of damage will happen? What do we have to do? So it's very similar kind of business. And I'll just leave my contact information here and be happy to take any questions. And I think I did it just about on time. Great.
Thank you very much, Dr. Geller. That presentation was amazing, and we know all of our listeners will benefit greatly from it. So at this moment in time, Dr. Geller will take any questions. You can submit your questions by writing it in to the question box, and we'll read them aloud, and Dr. Geller will answer for us. There's one question here, and the asker wants to know, are there any epilepsy centers in Connecticut? And I don't know, Dr. Geller, if you want to answer that, but we as the Epilepsy Foundation of New Jersey can help you find the affiliate that's closest to you by visiting www.efa, like Epilepsy Foundation of America.org. And there will be a place where you can type in your zip code and you'll find the affiliate that's closest to you. But Dr. Geller, if you have any additional information.
Sure, absolutely. In New Haven at Yale University, there is an excellent epilepsy center, one of the leading ones in the country and in the world. I believe in Hartford there's one. There's been one at the VA hospital, the Veterans Hospital in West Hartford for many years. And I'm sure there are several others that have grown up, so several smaller centers. But yeah, there's definitely good epilepsy care available in Connecticut.
Thank you very much. The next question is, do people remain on their drugs after surgery?
Great question. The goal, as we see it, from the medical side, is we want to get rid of the seizures. We want to get rid of the disability as a result of the seizures, get somebody back to working, driving. We'd like to reduce the medication if we can, but not everybody can come off medicine. In some cases, we turn the epilepsy, rather than getting rid of it completely, and you don't need medicine at all, we turn the epilepsy from one that is not controlled by medicine into one that is controlled by medicine. And I definitely have people in my practice who stop their medication and end up having seizures again. So there can be some significant risk of having seizures again, particularly after you've been through something as big as brain surgery. You may not want to mess up the progress that you've made. But I do understand that taking pills, it's a pain to take a pill every day. They may have side effects. They cost money. Obviously, many people like to get off the medication if they could, but not everybody can. That's an important discussion to have with your doctor one-on-one with your particular situation.
Okay, thank you for that. The next question is, can you speak a little about Dravet syndrome or severe myoclonic epilepsy of infancy?
Oh, sure. That's another epilepsy syndrome, like I was talking about, figuring out what kind of syndrome somebody has. And if you can identify Dravet's, that tells you a lot. Dravet's, in many cases, I think about 80% of people, you can find a particular genetic abnormality in what's called the sodium channel in the nerve cells. And that's what allows sodium to go from the blood and into the nerve cells and carry electrical signals. And in Dravet syndrome, it starts in early childhood, and there may be very frequent febrile seizures with fever that are sometimes very prolonged. Very often there may be status epilepticus, or very continuous seizures, and the seizures may become harder and harder to control. They may seem easy to control at the beginning or just with fever, but then become harder and harder to control. And then there may also be some significant developmental delay that develops, and learning problems, and loss of brain function over time. It seems like preventing the status epilepticus may help preserve some brain function, so it's important to treat. For example, if you had a child with febrile seizures, often we don't treat with daily medication. We just give medication to take if the seizure is happening. But if we identified Dravet's, we would have somebody on medicine every day to keep them from going into seizures. Dravet syndrome is also important to identify because some of the seizure medicines that are very commonly used, like Dilantin or Lamictal, may actually worsen the condition. So we avoid those medicines in Dravet syndrome. That's why it's important to identify.
Okay. Next question is, while taking seizure medication, do other meds affect the blood levels?
Great question. That's exactly what happens, and that's a very important reason to do blood levels. Some medications that we use for epilepsy particularly will go through the liver, get out of the body through the liver. So other medicines that affect the liver and cause the liver to be more efficient or less efficient may affect the levels. For example, somebody taking carbamazepine or Tegretol. Tegretol both revs up the liver and chews up other medicines faster. In addition, it's affected by things, for example, like birth control pills. So if you're taking the two of them together, the seizure medicine may not stop the seizures, and the birth control pills may not control births. So the worst of all possible worlds with those two things. If you take an antibiotic called erythromycin with carbamazepine, that slows down your liver. The carbamazepine levels shoot up very quickly, and somebody gets very dizzy, unsteady, throwing up, maybe very sick. So if there are people taking multiple medications, their doctors need to keep an eye on the blood levels. Some medicines like levetiracetam or Keppra or gabapentin, also known as Neurontin, don't go through the liver, are not affected in that way, and are safe to use with other medicines without checking the blood levels as frequently.
Okay, thank you. If you have a drop seizure after split brain surgery, does that mean it was not a success?
Well, certainly we don't want any seizures after surgery. We gauge success in epilepsy surgery in kind of a graded fashion. We'd love to have everybody seizure-free. Some people continue to have small seizures like their auras but don't lose consciousness. We still consider that a success. Some people may go from having very frequent seizures, like maybe several times a week, to having them just a few times a year. And while that's sort of technically a failure, we didn't get rid of the seizures completely. We did, having fewer seizures like that is much better in terms of quality of life. And some people, for whatever reason, continue to have seizures without any change. And in that case, it seems we kind of missed the boat and didn't take out the correct spot. That's why a very careful evaluation before surgery is necessary. It's kind of a cliche, but the old carpenter is saying you want to measure twice and cut once. So it's better to have a lot of testing, really figure out where things are coming from. Having a seizure right away after the surgery is a little more worrisome, although I have had people in whom we were able to get things under good control. And one woman that comes to mind had a few seizures with cutting down medicine right after surgery, and she's been seizure-free for over 10 years now and doing great, driving a car. Seizures may kick up in the future, though. If you look at how people do many years, 10 or 20 years after surgery, there's some percentage of people who will start having seizures again or have a few seizures. Usually the seizures are much easier to control after surgery if they do occur.
Okay, thank you, Dr. Geller. And I guess the piggyback question, which you kind of were just answering, what percentage of people are controlled after surgery?
It depends on what kind of surgery you're doing. You don't want to compare apples and oranges. If you look at the most common kind of surgery, which is the temporal lobe surgery, for that scar in the temporal lobe, mesial temporal sclerosis, in the first year to 2 years after the surgery, about 80% or more of people, that means 8 out of 10 people, will stop having seizures, which is great. If you look at 10 years out, that may drop down to about 60% or 50%, stay completely seizure-free. So there may be some people where the seizures have kicked up. If you look at other types of surgery, for example, if you're going after a benign brain tumor or a blood vessel malformation, if you can get out the entire abnormality with the surgery, then you may get rid of the seizures completely. That's an excellent prognosis. If you can't take the whole thing out, for example, if some of the tumor or some of the blood vessel abnormality is near the speech area or the movement area and you can't take that out, then you're not going to get rid of the seizures completely, but you may improve the seizures, make them fewer or milder. Other types of surgery where we know the seizures are coming from one part of the brain but the MRI is normal, that has a lower chance of completely stopping the seizures.
Great. Next question is, what are the best results for children with status epilepticus and EEG patterns of LGS? And then can you speak a little bit about ONFI?
Can you repeat the EEG patterns of what?
Of LGS.
Oh, LGS, Lennox-Gastaut, okay. Yeah, Lennox-Gastaut, as I was mentioning earlier, here I'll go back on the slide if you can still see my slides.
Yep, we can still see them.
Okay, great. So as I said, Lennox-Gastaut is one of our hardest to treat conditions. There are multiple types of seizures. People are typically on more than one medication to control the seizures. There is the developmental delay that makes everything more difficult as well. So we may need a different variety of ways of attacking the seizures. And one is medication. Onfi is also known as clobazam. In Europe, the name was Frisium. Many people tried to obtain Frisium from overseas before it became approved here in the United States last year. Onfi is related chemically to some other drugs that we have available here, Klonopin, Ativan, Valium. These are all in the family of what are called benzodiazepines. They also work on anxiety as well as seizures. And Onfi has approval from the FDA, from the Food and Drug Administration, for treating Lennox-Gastaut syndrome. There are several other drugs that have been tested and approved for Lennox-Gastaut, such as Felbamate, Depakote, valproic acid, lamotrigine, topiramate or Topamax, and other ones that can be useful are levetiracetam or Keppra, zonisamide or Zonegran, and sometimes we'll just use Dilantin. You need to go with the oldie but goodie. Because we're using multiple types of medications, there may be lots of side effects from the interactions of the medications, or the side effects just add up. So it's a difficult treatment problem. What I find very successful often is adding something like the vagus nerve stimulator, which is a pacemaker. I didn't really talk about that in the diagnostic talk here, but in treatment talks I talk about it. Which gives therapy all the time and in many ways has much fewer side effects than the medications. Sometimes we'll use diet therapy with the ketogenic diet or the Atkins diet to try to help the seizures, and that can be very successful sometimes. But when I talk about successful, it's relatively. It would be extraordinarily unusual for somebody with Lennox-Gastaut to become completely free of seizures for a long period of time.
Okay.
Okay.
Next question is, do seizures or the medication themselves decrease memory function?
Great question. Yeah. For people who come into my office, the number one complaint is the seizures, and the number two complaint is the memory. It's very, very common. The most common problem is in temporal lobe epilepsy, because the temporal lobe part of the brain is important for short-term memory. And that's where you learn things. And when it's not functioning right, then you have a lot of trouble learning, remembering. Partly it depends on which side of the brain. If it's on the left side of the brain, which is usually the speech area, you may have trouble particularly with words, remembering things that you've read, remembering conversations you've had or things that have happened. On the right side of the brain, it's more visual memory problems, for example, getting lost, not being able to tell landmarks, recognizing faces. However, in other seizure problems too, even so-called benign ones like juvenile myoclonic epilepsy, people may have some memory problems. There seem to me to be three main issues with the memory. Number one is seizures can certainly interfere with memory, so we want to get the best control of the seizures that we can. That usually means more medication. Number two, the medicines can interfere with normal brain function. Even though they're aimed at abnormal brain function, they cut down normal brain function as well. And at high doses, or certain of these medicines that are more sedating, make you sleepy, may cause memory problems. So in that case, we want less medicine rather than more medicine or different medication. And then the third issue is whatever the underlying problem that's causing the seizures may also be causing the memory problem. So it doesn't matter how well you control the seizures, there's still damage there that's preventing the memory from working well. So what we can do is, A, try to make sure that seizure medications are at a good level, that we have the best control of the seizures possible, and switch to medications that may have fewer problems with the memory, but sometimes there's a limit to what we can do. Memory tends to be worse in people who've had a lot of grand mal seizures. The really big grand mal seizures tend to affect that part of the brain in the temporal lobe. And even if there are no further seizures, it may just cause some injury or damage that affects the memory.
Okay. Thank you. Next question, and one after this, one more. Who is a candidate for the VNS?
Who are candidates for VNS? Great question. There's sort of two answers to that question. The Food and Drug Administration says that based on the studies, the approval is for people with partial epilepsy who are 16 years and older who have seizures that have not responded to medication. However, we find that people with Lennox-Gastaut syndrome, for example, or other types of generalized epilepsy may respond extremely well, and I think, in my opinion, even better than people with partial epilepsy to the vagus nerve stimulator. So in my mind, the VNS is really an option for anybody who has seizures that are not controlled by medication. And it offers much fewer side effects in the medicine. It can't hurt the liver, the blood, can't cause a skin rash, doesn't make you drowsy or dizzy, shouldn't affect your memory in a negative way, shouldn't affect your mood in a negative way. All the side effects are related to a branch of the nerve that goes to the throat area, and it may cause some hoarseness or cough as it cycles on and off. But usually that's something I can adjust in the office very easily and prevent those kind of side effects. Unfortunately, unlike the medicine where if you get somebody on a new medication and you get a good blood level within a few days or a few weeks, it should be working right away. If it's not working, if they're still having seizures, then you know it's not working. With the vagus nerve stimulator, there seem to be effects that build up over a long period of time, and it can really take about 1.5 years or 2 years to see the full benefit. So you really have to stick with it and work hard with your doctor on finding the highest possible settings that are tolerable, and give it some time. But in my personal opinion, this is not an FDA-approved thing, but in my personal opinion, really anybody with any type of hard-to-control seizure problem is a candidate for the vagus nerve stimulator. However, I would just take a step back and say anybody who's been through all this diagnostic testing that I just talked about. There have been a few cases of people who were referred for vagus nerve stimulator, and it turned out they actually didn't have epilepsy, and they hadn't been through the testing to prove the seizures or not. So I'd like to find out, is there some other more standard therapy? For example, is it just they're on the wrong type of medicine? They're on a medicine for temporal lobe epilepsy, and really they have absence seizures and they need a different medication. Or are they a candidate for brain surgery? Because vagus nerve stimulator has a fairly low rate of completely stopping the seizures, whereas brain surgery, as I said, may really dramatically eliminate seizures in many people. So vagus nerve stimulation is a good option after somebody's had a thorough evaluation.
Okay. How does being left-handed have an impact on seizure control or on surgery outcome?
Well, as you know, most people are right-handed. Some people are ambidextrous, use both hands, and some percentage of people are left-handed. A small percentage of people are purely left-handed. And what that means is almost everybody who's right-handed has their speech abilities on the left side of the brain, because the left side of the brain controls the right side of the body. People who are left-handed, even most of them have their speech abilities on the left side of the brain, but some have actually switched and have their speech abilities on the right side of the brain. So it really doesn't have an impact on seizure control specifically, but it's important if we're evaluating somebody for surgery. That's why neurologists always write down, is somebody right-handed or left-handed. That's why we ask that the first thing before we get any of the history. Are you right-handed or left-handed? To give us an idea of how your brain is set up, how it functions. And if, for example, somebody's right-handed and we're going to operate on the right side of the brain, then there may be some tests we can skip, like the WADA test, because we know the language is going to be on the other side of the brain that's not involved in surgery. If somebody's left-handed, it's a little more of an open question, and we need more careful testing to figure out which side of the brain is involved with the speech. So just being left-handed doesn't make you harder to control with medication or anything like that, though.
Okay, and this is the final question. How does Keppra hurt or help memory in people with absence seizures?
How does Keppra work to help memory in absence seizures? Really, the main problem with memory in people with absence seizures is that the absence seizure is interfering with information coming into the brain. Your brain is just kind of having a brownout during that time, and if not a full blackout. Imagine you're sitting in the classroom and you're trying to write down what the teacher's writing on the board, and somebody keeps turning out the lights for 10 seconds at a time, and you can't see what the teacher wrote, and then she erases something, and then suddenly it's all gone. That's what it's like with absence seizures. And so if there's full control of the absence seizures, it shouldn't really matter what medication is doing it. I would expect the learning and the memory to be better. The way Keppra works in the brain is not fully understood. It seems to have some effect on how nerve cells communicate with each other, release chemicals from one to the next to send signals, but we don't have a full understanding of why it works for seizures, and to my knowledge, it doesn't have any specific effect on improving or making memory worse.
Okay, thank you, Dr. Geller. That was our last and final question, and we have a couple of thank yous coming through on the question section, so our audience definitely thanks you. The Epilepsy Foundation of New Jersey thanks Dr. Geller also. We want to recognize him and thank him for being the vice chairperson for the New Jersey Epilepsy Task Force. I know you're working diligently to change things for the lives of people living with epilepsy today. So we thank you for that, and we thank you for presenting tonight's webinar, and it will be available on our website, www.efnj.com. And thank you again, Dr. Geller. We appreciate it.
Great. Thanks for having me. Always a pleasure.
All right. Good night.
Bye-bye.
The organ